All right, everyone. I'm Moayedi. I'm one of the faculty here at the University of Maryland. My shtick in emergency medicine is procedure education and invasive medical procedures. I have a lot of CME courses, and I can talk about that at the very end. It's an honor to be with all of you today. For those of you who are connected to the internet via a computer, my opinion of education is you have to be active and participate. And so Poll Everywhere is the software that we've been using with the medical students, and it's been working really, really well. So go ahead and just log into pollev.com/UMEM. If you are connected with a cell phone, then you can just text the letters UMEM to the number 37607, and we can participate. And just to see if it's working, let's see where you are. I'm curious to know where everyone is joining from. The next slide, we're going to talk about who you are, what level of education. Are you an EMT? Are you a nurse? Are you a physician, medical student, all that stuff. I'm not going to spend too much time on this, but this is a representation of who's out there. No one from Antarctica yet. I was expecting at least one, though. So it looks like primarily from North America, maybe Canada, US, Mexico, and a handful from all the other continents minus Antarctica. All right, we're going to close that. We're going to move on. Tell me who you are. I'd love to know who we've been lecturing to this morning. Looks like a lot of residents, a lot of physicians, students, physician assistants, nurse practitioners. I'm going to leave this open a little bit more, but I'm getting a sense that there's a lot of residents out there, so welcome everyone. All right, let's move on. So, how many of you have floated a transvenous pacer in the past month? Very little, right? And so that's the point of this whole lecture is this is a rare procedure. And the objectives for me is within the next 20 minutes, I want all of you to feel comfortable how to program this device, the pacer box. I want to, in the next 10 minutes, go over the systematic approach of, step-by-step putting this pacer wire in. We're going to talk about troubleshooting. So, you've given yourself a high five, you've given the entire room a high five after you've floated the transvenous pacer successfully, and then 10 minutes later when the nurse says, hey, patient's heart rate is back in the 20s, I want you to know how to go back and look at the rhythm and figure out how to troubleshoot. And just for entertainment, we're going to show you 3 videos of people making bad decisions and electrocuting themselves. All right, so it all starts with a really good case, and this is my personal case. I've been practicing emergency medicine as attending for over 16 years now, so this is 15, 16 years ago when I was fresh out of residency, and I'm sharing this story. So EMS had found a patient altered in the streets, very close to the emergency department where I work. They scooped him up, brought him in. We realized that he was obtunded, unresponsive, low blood pressure, very low heart rate. Put him on a monitor, low heart rate. All my students know you check AVO2 monitor, finger stick for altered mental status. We did all those things, not hypoglycemic, but the monitor did show a bradycardia. And so that led to getting the EKG, and the EKG showed a slow heart rate. So we went straight to ACLS and said, ACLS, what do you say to do in this case? And if you have persistent bradycardia, that's symptomatic, and for sure this guy was symptomatic, he was hypotensive, he was altered, you go to atropine. So I gave atropine and nothing happened. What's the next thing ACLS says? Well, next ACLS says, hey, why don't you try some transcutaneous pacing? So we did, and I connected the pacer pads. Let me see if I can come out here. Anterior, posterior is probably the best way to place the pacer pads even for cardiac pacing. And what I saw was a obtunded man groaning, and his left pectoralis muscles more than the right were just flailing. Thought it was working, checked the pulse. Usually I like to use a pulse ox, but you can't put it on arms because their arms are flailing with all the muscle contractions. I put it on his toe, and no, his heart rate was still 20s. So what does ACLS say to do next? Dopamine, epinephrine, those are not readily available. At least back then, they definitely weren't readily available. We tried it, they weren't working. So then ACLS says, hey, why don't you float a transvenous pacer and call a consultant? Sometimes that consultant can be a cardiologist. Sometimes that consultant can be a toxicologist. So we started trying to feed this transvenous pacer, okay? Now, I promised some videos of people making mistakes, and this is an electrified fence. It's not insulated, and I had to go through hours of this stuff, and my kids were loving it yesterday when we were trying to figure out what the best ones were. All right, so what we're going to talk about is the tools in the next couple of minutes. What you need is a 6 French introducer. This is not that large volume, trauma resuscitation line. This is a 6 French introducer, and the reason it's 6 French is because this pacing wire is 5 French, and so it has to be able to fit in there. Of course, you need your pacer box and your little connector. That's useful so that people don't trip over it when they're plating it in. And then the pacer wire itself, and we're going to just demo the pacer wire in 1 second here. So let me switch cameras real quick. All right, so the pacer wire, and so for those of you who are at home, what you can do is you can click on the image that you see in front of you, and it will just zoom in that image. But essentially what you have is a specialty syringe that locks out at the maximum volume that the balloon inflates with. So most balloons are somewhere between 0.75 to 1.5 cc. 0.75 is the most common. And so this syringe here will max out at 0.75, and so you can't blow up the balloon. The other thing is it's a really good thing to test the balloon to make sure it's not ruptured. Otherwise, you're just giving air embolism in the right side the whole time. There are 2 connection electrodes. There is this one here, and if you focus it in a little bit, it says proximal or positive sign next to it, and then there's the distal one that has a negative sign next to it. The only other thing I want to highlight is every 10 centimeters, there is a nice little hash mark, and those hash marks tell you where you are with respect to the patient's heart. So focus a little bit more on this connector. Sometimes the manufacturers and the manufacturer of the pacer wire don't talk to each other very well, and so just have a positive sign, and on their connector it just says proximal. So the trick to remember this is just connect P to P, positive to proximal. All right. Now let's talk a little bit about the box itself. Let me switch cameras. All right. So the box has 3 simple dials. The top one has to do with the rate. Rate of 80 is perfect. That's what we want. They came in with a rate of 20. You want them to have a normal rate of 80. The next one is the output. Everyone's familiar with output because you've transcutaneously paced other people. You basically dial it. Now, for transcutaneously pacing people, you need a lot, an order of magnitude more energy, right? So I transcutaneously pace myself during lectures sometimes for the students, and my pacing threshold is somewhere around 70 milliamps, right? Here, the maximum you can pace somebody with is 20 because you're inside of the ventricle. You're inside of the right ventricle, and so you need an order of magnitude less. So anywhere between 2 to 5 is plenty millivolts. Now the third one, this third knob, this is the one that trips everybody up, and this is what we're going to focus on for the next couple of slides. So this sensitivity measured in millivolts is what I want to talk about a little bit more because that's what trips people up. All right, so the way I want you to think about what sensitivity is, it's you programming the computer, this pacer box, to recognize what a QRS is. And if it recognizes a QRS, it will hold pacing, okay? So if you set it on 3, here, it means that anything that is above and more than 3 millimeters of amplitude is considered a QRS complex, and it will not pace during that time, okay? On the other hand, if you make it least sensitive, and this is the part that sort of confuses people, if you make it a higher number, you're making it less sensitive. You're saying, hey, you're going to need 20 millimeters of amplitude for something to be considered a QRS. And that's rare, right? And so if you make it that less sensitive, if you crank it up all the way to 20 and beyond, it's going to just basically pace and be blind and say, nothing meets criteria for QRS, I'm not going to block anything, I'm just going to pace steadily. And on the other hand, if you make it the most sensitive, so 0.5 millimeters, well then pretty much any little blip may be considered a QRS. A P wave will be considered a QRS, and it will hold and pause, okay? So let's explain this another way. So I've made this very, very high threshold of what a QRS complex is. So it's a very low sensitivity, and it's just going to pace at its own rate. It's going to be asynchronous, and it's just going to pace at the rate that you set. So if you set 80, it's just going to pace at a rate of 80. On the other hand, if I make it most sensitive, what's going to happen is it's going to pace when it doesn't recognize anything that's less than 0.5, but once it sees this little P wave here that is more than this little P wave, sorry, it's a little lag. This little P wave here, is it working? Anyway, then it's going to recognize that as a QRS and hold and not pause, and not pace. All right, let's talk about how to approach. So we talked about how you need a 6 French introducer, and the ideal place to place it is the right IJ. We're all facile with ultrasound. Everyone knows how to do ultrasound-guided IV very easily, and the right side is a direct shot into the superior vena cava, into the right atrium, into the right ventricle where you want the tip of your patient wire to be. Okay? If you don't have that option, try the left subclavian. That's also a natural arc that will have the wire go directly into the vena cava, into the atrium and ventricle. Typically, we try to save this because if the patient needs a permanent pacemaker, the electrophysiologist, whoever is putting in the permanent pacer, would like to use the spot and have it sterile. All right. Now, what we're going to talk about now is the step-by-step technique of how to put this pacer wire in, and we're going to use what's called the blind technique, and I'll explain what that is in the next slide. So, for the blind technique, what you're going to do is you're going to program your box, and you're going to set your rate at 80. Okay? Talked about how 80 works for everybody. Then you're going to take your output and you're going to crank it up, and 10 is plenty. Okay, so that's in millivolts. And you're going to take your sensitivity and you're going to make it least sensitive. You're going to make it into an asynchronous, just it's going to blindly pace whatever it sees. Okay, so that's the setup for the blind transvenous pacer spot. All right, now I'm going to switch cameras and we're going to demonstrate the rest of it again. All right, so you have the 6 French introducer ready to go. And this, incidentally, is not real skin. It's a manila envelope that I put down there on a shoebox. The first thing you find in your kit is this little doohickey. And this little cap is going to help secure the wire. So we're going to demonstrate how we put that on. And once you put it on, it looks like this. Okay? The next step that a lot of people forget about, and that's super important, is to take your sterile sheath and have that sheath, put your pacer wire through it. If you don't do this step right now, you're going to have to redo the entire process because you're going to have an unsterile wire that you can't adjust the position of. Okay? So Dr. Tweld has fed the pacing wire through the sheath. Okay? The next step is to start advancing the wire. I'm going to move the camera a little bit better here. Oh, sorry, too much. All right, so we're advancing the wire until we get to the 2 hash marks. So that's 20 centimeters, right? And once you get to the 20 centimeter mark, that's the time that you know that the tip of your balloon, the end of your pacing wire, is out of the introducer sheath and it's dangling somewhere in the superior vena cava. And that's the time to inflate the balloon. Okay? So now the balloon is inflated. Right? And now we're going to just look at the monitor and continue to push the wire forward until you see capture. And the capture is going to be a left bundle branch block pattern. I'm going to switch cameras real quick here so you can see me again. So the capture is going to be a wide QRS complex. It's going to look like a left bundle because your electrical impulse is starting in the right ventricle and it's slowly going over to the left ventricle. And that's why you get this widened QRS. Okay? So that's what we're looking for. As soon as you see that capture, meaning a pacer spike, here's a pacer spike, followed by a wide QRS, you're going to stop advancing and you're going to deflate the balloon, okay? Because you don't want to keep advancing the wire. If you keep advancing the wire, it's going to turn into a pulmonary wedge. Okay, we don't want to do that. Now, that's electrical capture. You want to confirm that your patient actually has a pulse from this. And again, a pulse oximeter is perfect for this. And in this case, you don't have to put it on their toes because it's such little millivolts full voltage that if you have it on their finger is not going to be moving, and you can get a good, reliable pulse. Now, for those of you who have access to ultrasounds, this is actually a perfect time to use ultrasound from the get-go. You're going to have a second operator just having a subxiphoid view the entire time, and you're just going to look for this echogenic structure, the pacing wire, entering into the right ventricle. And as soon as it enters to the right ventricle and touches the apex of the right ventricle, you're going to see the entire myocardium start to go at the rate of 80. And so that's another cue that you can stop and deflate the balloon. Okay? So I'm going to switch the camera one last time. All right, so now that you have stopped, I'm going to zoom out for you a little bit. Let's see. Now that you have stopped, what you can do is you can now tighten that first twist, and so what that does is it actually clamps onto the wire so it doesn't get accidentally pulled out. So when the grandson comes to visit grandma, in whom you just fed this transvenous pacer, the grandson can't accidentally trip on it and pull it out. Okay? So that's step one. And step two is you're going to take your sterile sheath and you're going to just pull it all the way out and make the entire wire sterile so that if you need to make adjustments in the near future, you can do so sterilely. And that's why it's so important to feed your wire through the sterile sheath. All right. And that's the end of the demo. All right. So what next? The next step is you're going to line everything straight up like that, right? So you already had the rate of 80. Now you're going to decrease your output to about 5, and you're going to decrease your sensitivity to, you're going to increase your sensitivity by bringing it to a level 3. And if you notice, it's all going straight up. And that's why these machines are so lovely, because they're actually designed so that if you line up everything straight up, it will work for you. If you want to be a little bit more nuanced to figure out what the pacing threshold is for your output, then what you can do is you can sort of, remember we started at 10 when we were blindly feeding it, and at this point you have capture, wonderful. Then you can sort of turn it down and you'll lose capture. So you see pacer spikes, but you don't see any capture anymore. And then what you can do is just gently, slowly go back up a little bit, and suddenly you have capture again. And that's what the pacing threshold is. And now you've decreased, the probability of causing some myocardial damage and essentially ablating it a little bit by using a little bit less milliamps. All right, I promised 3 videos, so here's the second video. So this one is electric fence versus teenager who wants to touch it with his tongue. That's amazing. My kids like that one the most. All right, let's talk about troubleshooting real quick. So, like we said at the beginning, you floated this transvenous pacer, everything was great, and then the nurse comes and says, hey, unfortunately the patient's heart rate is back to the 20s. The way I want you to think about failure is you either have failure to pace, you have failure to sense, or you have failure to capture. This is the simplest way in my mind that works for me, and I'm sharing it with you now. All right? So, back to the pull everywhere. What I want you to do is now take about 15 seconds and look at this rhythm strip here and someone who was paced, and look specifically for pacing in there and see what's going on. Is this failure to pace, failure to sense, or failure to capture? And I on purpose have closed this so you can't see the answers, but I'm going to now share it so everyone sees what the world is deciding. Yeah, so the majority is correct here. This is failure to pace. Let's walk through it real quick. Okay, so pacer spike, wide QRS complex in the left bundle pattern, wonderful. Pacer spike, left QRS complex, left bundle looking wide QRS complex, wonderful. And then I don't see any pacer spikes anywhere. So this is failure to pace. And usually this happens from meaning this has been sensed as a QRS complex, and so the machine decided to withhold pacing. But sometimes it could be because you're running out of battery, or it's because the grandson or the grandchild accidentally, tripped on the wire and pulled it out a little bit. All right, what about this one? Let's see if we can unactivate this one. So I'm going to clear the responses from the before and take off the. All right, I'm going to give you another 15 seconds. So again, the trick here is to look for the pacer spikes and see what's happening. So before, there was not even any pacer spikes, so that was failure to pace. Now, follow the pacer spikes and let's figure out what's going on. All right, let me open it up so you guys can see what your colleagues have decided. A lot of people are saying failure to capture. Some people are saying failure to sense. Good, I'm glad we're doing this. Okay, so let's systematically look at this again. So, pacer spike. Nothing's happening, but maybe nothing's happening is because the reason nothing's happening is because it's during a refractory period here. But then a pacer spike here, and there's a nice wide QRS complex, and then there's a pacer spike here, but there was a natural QRS complex, and this is happening, whoa, on a T wave. That's really scary to me. And of course, nothing happens because it's during a refractory period, but it's a dangerous area here. And then pacer spike, wide QRS complex, and then again, a native P QRS, and then, oh my God, that's exactly on top of the T, and you got lucky with that one. So what this is actually failure to sense, okay? And so the treatment for this one is to just increase your sensitivity, and you remember, increasing sensitivity means decreasing the number of amplitude that is registered as a QRS complex, okay? So, one quick pearl for you. In the very beginning of our case, we tried to pace them transcutaneously first, right? And we left those on because of this potential for failing to pace. And holy cow, an R on T phenomenon happened right here, right? It paced right in the middle of that T wave. And when you do R on T, when you pace on a T wave, you get ventricular fibrillation. So thank goodness we had that pacer pads on, because now we're going to use it as defibrillator pads. Switch the machine back on to defib mode, and this is 200 joules as fast as you can. Okay. If you're using a biphasic machine. All right, last one. Let me clear these. These are from the last one. We're going to take off the responses so no one is peer pressured into answering. All right. So again, look at the pacer spikes and figure out what's going on. Or just deduce that we went through the top two, so it must be the third one, right? All right, so show responses. Everyone's going for failure to capture. Let's go through it systematically. So these two, everything's working great. Pacer spike, wide QRS, pacer spike, wide QRS, pacer spike. Nothing happened. This patient is kept alive by this escape rhythm, or this sort of like lucky rhythm there. And then this gave a pulse to the patient, and then pacer spike, nothing happened. So what's going on here? This is failure to capture. Usually this is related, again, to positioning of the cable. It got yanked out. Or it could be that someone was messing with the output, and the output is not enough, and you need to go up on the output a little bit more. Or it could be that your patient has some underlying issues, that their myocytes are not responding to depolarization. Maybe it's related to severe acidosis. Maybe it's related to hyperkalemia. So sometimes those patients are just not amenable to pacing. Okay, last video. This one is my personal favorite. I'll set it up for you. The story is that this gentleman here has strapped a dog collar, that shock collar, to his right side, I think it is, and he's walked into this deli, and this is what happens when you have bad decisions. This guy gets too happy with it. I'm sorry, the video there. All right. I hope you guys enjoyed those. All right, so let's go back to our case. Remember, this guy was found outside the emergency department. I was brand new attending. I was following ACLS guidelines. He was bradycardic. I had given atropine. Nothing had happened. I had tried to pace him. His arms had flailed, but his blood pressure and his heart rate had not improved. And so I was in the middle of needing a transvenous pacer when the lab called, and guess what they told me? Everyone here is shaking their heads. Yes, this was the routine rookie mistake. This patient had severe hyperkalemia. They called me with a critical value of a 9.5 potassium value. It turns out I never should have even thought about pacing this guy. Imagine what was happening when I was pacing him and he was lysing cells, right? We were just actually increasing his potassium as he was like, breaking cells and going into rhabdo. And so all I had to do is sprinkle some calcium in this guy, and this is his own EKG afterwards. The why didn't cure us, the prolonged PR, the prolonged QT, all that stuff improved. His bradycardia improved. It turned out he was actually a dialysis patient who had missed dialysis for a long time. The dialysis active site was in his groin. We never took his pants off. So I learned a lot of valuable lessons the first year out of residency. All right. I have just a very little bit of time. Quick advice for those of you who have decision-making capacity. If you have the choice between this one and this one, pick the one that has the dials, because that's the one you can just put straight up. The one that is digital is harder to use, and when you're in a chaotic code scenario, it's a bad idea to use that. All right, just to review very briefly, we talked about how sensitivity works. When you have a higher number, it's actually least sensitive. We talked about using a 6 French introducer because your pacing wire is a 5 French. We talked about P to P, proximal to positive, when you're connecting it to your connector. We talked about failure to pace, sense, and capture, and it has all and everything to do with what's going on with the pacer spike, if it's there, and if it's there, it's conducting. We talked about having your pacer pads on and using them as defibrillators in case you have this failure to sense issue and an R on T phenomenon. And we talked about, hey, consider that maybe it's a metabolic derangement that's not going to respond to your pacing in the first place. And so do not pace hyperkalemia. Don't make the mistake that I made when I was out of residency. All right? So I'm going to finish there. I'm happy to take some questions. Just when this COVID business is over, I would love to have you over at University of Maryland. We have a lot of CME courses. This one particular one called Critical Procedures in Emergency. Actually, I have the wrong name for it, but it's Complex Procedures in Emergency Medicine. We talk about Blakemore tubes and transvenous pacing and pigtail catheters and vertigo maneuvers, all that stuff. And I'll stop right there. I'll take any questions.
Mac, I got one question. Can you clarify the role of the balloon and also when to inflate and when to deflate?
Yes. So the balloon serves as a way, it's like a puff of cloud, and it's filled with air, incidentally, and it helps guide the pacer wire with the venous return pushing this pillow of air towards the right ventricle, right? So you're in the venous system, you're starting in the IJ, you're in the superior vena cava, and you want it to go into the atrium. You don't want it, if you just randomly push, it might go down into the inferior vena cava. So the balloon will help guide it with venous return down towards the right atrium, right ventricle.